The new products respond in a different way to the conventional laboratory tests. Which assays are the most appropriate with the new products?
So I think this is a time when the difference one-stage chromogenic has never been more important. I think we should differentiate a little bit between factor 8 and factor 9. The new extended half-life factor 8 products, I think the ones we've now studied, the ones where data is available, for all of these we can probably use a chromogenic factor 8 assay to monitor post-infusion therapy. So I think that's convenient. This way we don't need to know which product the patient received. We can always use the same assay, and that's really convenient for the lab. And in any case, we must have a chromogenic factor 8 assay even before treatment, because we need it to diagnose all of the patients with mild haemophilia. It's an essential part of the testing during the initial diagnosis. So we've got to have it in a good haemophilia centre. Turning to factor 9, it's a little bit more complicated, I think. We don't have a single assay that I'm aware of that can definitely be safely used with all of the different extended half-life factor 9s. Chromogenic is okay for some one-stage assays are okay for some, but we don't have a single answer. So in this case, we really need good information. Which product did the patient receive before we can make our decision in the lab? Never been more important.
And also have a battery of reagents.
And it means for factor 9, we have to have more than one method available if we are using different concentrates in our patients. It's a bigger problem for the lab than in the past.
And what about pediatric patients?
Well, so I think thinking about pediatrics, it's more or less the same issues. In terms of assays, we're not going to see any differences in terms of the chromogenic one-stage pattern in adults. It'll be a similar pattern in children. Pediatrics, of course, the half-lives are going to be different, but nevertheless the issues are the same. So I don't think we've got any issues particularly just for pediatrics. Same problems, same solutions.
And with the advent of monoclonal antibody products, do you still need to measure?
So this is an exciting time. Just now as we're talking, I'm really disappointed I couldn't go into the late breaking abstract session where there was some information about one of the monoclonal antibodies, the bispecific antibody emicizumab, Hemlibra. This will cause particular issues in the lab. Even a single dose will make APTT totally normal in all patients by all reagents that I've seen. When it comes to measuring the activity, probably we will need to measure surrogate factor 8 activity that antibody delivers if we want to look for possible loss of drug, perhaps through a neutralizing antibody. And we can do this with the chromogenic assay if the chromogenic assay has human 9A, human 10 in the lab reagents in the kit. Some do, some don't. On the other hand, when we want to make a Bethesda assay to check the inhibitor level, licensed at the moment for patients with inhibitors, I missed the talk that might tell us more, but anyway, there we want to measure the real factor 8. In that case, a different chromogenic assay, this time where the 9A and 10 in the reagents must be bovine, or at least not human. And they're available also, so there will be some big issues.
Will the haemophilia centres become obsolete?
Absolutely no. It will be more and more important for this care to be delivered in a specialist haemophilia centre. It's never been more important. If we allow a disconnection between the laboratory testing and the colleagues treating patients, if this is permitted, this will have really serious consequences, not just for patients, but for healthcare budgets. The treatment will not be effectively done, the resources will be wasted, there'll be big patient safety issues. Now more than ever, it's essential that close relationship exists between the specialist laboratory and clinical colleagues treating patients. Really important.
In the UK, do you still have specialist coagulation laboratories, or has centralisation prevailed?
So in the UK we continue to have specialist coagulation laboratories. It's a fight. The administrators who make simple decisions, who don't understand, take the view that perhaps it would be cheaper to do these tests in less expert laboratories. There's no way on earth it's cheaper. The lab costs might be, but the costs to the healthcare system are much higher because of the lower quality. High quality lab tests is cheap medicine. It saves money right across the budgets in other places. It gets patients discharged quicker. It frees up beds. It improves the quality of treatment. It reduces the complications, all of which is not just good medicine, it's cheap. Quality lab is cheap.